Good evening, everybody, and welcome to this class on intravenous fluids. In general, about fluids and electrolytes in surgery. Uh, Generally, it's considered a chapter or a subject which is boring. Most people do not focus on it, and because some of the explanations that you find in the books and certain talks make it a little complicated. People tend to switch off fluids and electrolytes. But believe me, the real advances in surgery, where you have managed to succeed after big operations like major resections and severe trauma or major sepsis and things like this, it is the metabolic support to the patient that really brings him out of difficulty. That's what really spells success in surgery. So it's important for us to know about, you know, fluid and electrolytes, acid-base balance, uh, antibiotics in surgery, what happens in trauma in terms of metabolic stress, nutrition in surgery, and things like that. And so, at least in the Sagar group, we are very keen that people, have a good introduction to these topics. And one of the common things that I do uh, when I give talks on this subject is to ask my audience two simple questions. What's the normal requirement of sodium in a day for a human being? And I'll say, what is the sodium content in 1 liter of Ringer's lactate? You know, the reason I ask this is that IV fluids that we give on a daily basis to our patients must be seen as a drug. It is a drug. It is nothing other than a drug. Just like you need to know about the dosage, the characteristics, the route of administration, the duration, and the method in which you give a drug, for an antibiotic, for example. The same kind of approach must be made to intravenous fluids as well. And so you need to know what are the fluids available, what are its contents, how do you give it, what are its good points, what are its bad points, and things like this. So that is something which we really need to understand. And Nikitha is our first year resident. She has just joined the course. And it falls on the first years to look at all these basic things like wound healing, trauma, response to stress, and IV fluids, and things like that. And so here we have Nikitha talking about intravenous fluids. Over to you, Nikitha.
Yes. Good evening, everyone. Today we are going to talk about intravenous fluids in surgery. So basically, humans are built with the oral feeding mechanism, but the reason we opt for intravenous route in surgery or medical practice is because of its fastest, as it is the fastest route and its bioavailability is 100%. So today we're going to talk about. One second, sir.
Yeah, sure.
The plan is, why do we need to give intravenous fluids? What are the type of fluids which are present, and the specific need for any type of fluid, and where do we give the intravenous fluids, and how do we give the intravenous fluids, and when are we supposed to give them, and do we have any substitutes for the intravenous route? The basic truths are, fluids which we give are drugs. Just as sir mentioned just before, fluids should be considered equal to drugs. We cannot overlook fluids by saying that they can't cause much harm, because their outcome depends on the metabolic care which we take. Learning about intravenous fluids is very necessary because they're an innate part of our day-to-day medical life. So before starting about intravenous fluids, let's get to know about the fluids of our own body. The total body water is the percentage of water present in our body, which is 70% in kids, 60% in male, 50% in female, and 50% in elderly age group. Out of
Go
the
just
50,
go back a little bit. Why do you think it is less in women, Nikitha, compared to men?
the metabolic rate is different for men and women, sir.
Not
And also
metabolic,
the
not
composition.
metabolic rate. Yeah, composition. Yes. What is the difference?
The muscle content is different for both, sir.
Not muscle. Pavan,
Pavan is in emergency, sir.
emergency. All right.
Sir,
Indraja,
fat content is more in
fat
females.
content. Correct. Fat is more in women, and fat is anhydrous. It has no water, and so overall body water in women is less than that in men. Go on.
So out of the 40% of the fluid, 40% of body water fluid, out of 100% of body mass, 60% is fluid. In 60% of the fluid, 2/3 is intracellular fluid and 1/3 is extracellular fluid. And we are mainly concerned about extracellular fluid because it has been divided into interstitial fluid and plasma. Plasma is the only thing we can manipulate directly through the intravenous route. So the general physiology of fluid movement, ionic movements of fluid movements, the cell wall of any cell is semi-permeable in nature in our body. The movement of water through the cell is free without, it doesn't need any energy, but the electrolytes or any ionic ions require energy to move across the cell membrane. The basic law of the cell is to maintain osmolar gradient, and the goal is to reach the neutrality.
All right. Let me chip in and help you with this. All right.
Yes, sir.
You go back one slide. Yeah, you mentioned correctly that when we manipulate the intravenous fluids whichever way we want, that can happen in only a very small compartment of the body, which is the intravascular compartment or the plasma compartment. But that is in dynamic equilibrium with the extracellular fluid, which is again in dynamic equilibrium with the intracellular fluid. All right, that is the first basic thing. Come to the next slide. And what is it that maintains that equilibrium? It is the fluid and electrolyte shift across the cell membrane, which is a semi-permeable membrane. Because it is semi-permeable, you can have differences across the membrane. If it is a completely permeable membrane, like you have in a dialysis membrane, for example, renal dialysis. So if you expose different solutions with different electrical components, which is the charged ions, and different osmolality, which is again the solutes in that cell. If you have a fully permeable membrane, like a renal dialysis membrane, for example, then fluids molecules shift on either side. Whatever is hyperosmolar on one side moves on to the hypoosmolar side. Electrical neutrality also moves. That means cations and anions on either side become balanced. And so you have the two sides of that fully permeable membrane with the same constitution after some time, once you allow time for this dynamic movement. But that cannot happen in life because you need to have, for homeostasis, differential electrolyte content and differential solute content across the membranes, even though there must be isoosmolality, osmolar concentration must be the same. There must be electrical neutrality, which means that the cations and the anions must be balanced on either side of a cell membrane. The content, which cation, which are the solutes which are inside and outside the cell, which are the cations and anions on either side of the membrane, they differ. That is a basic law of nature, and that differential has to be maintained. And that is something that we have to understand about basic physiology. And that maintenance happens because of movement of electrolytes in and out of cell. And this movement is energy dependent. And it is important that when ATP is not generated for whatever reason, hypoxia, hypotension, tissue hypoxia, the commonest cause, when that happens, homeostasis goes. And so understand that semi-permeable membrane and keeping a differential solute and electrolyte content on either side of the cell membrane, that is inside the cell and in the extracellular fluid, the differential is the basis of life, and that is energy dependent. All right, go on.
So the regulation of osmolality mainly depends upon the function of the kidney, as it filters out the solutes and conserves the solutes. It is the one which is maintaining the osmolality. Around 400 to 600 milliosmolar of the solutes are being dealt with on a daily basis by kidney. Conservation of sodium or excretion of sodium, conservation of water, excretion of water is all depending upon the function of the kidney. So these are the major things which makes the
homeostasis possible, which regulates. Osmolality is primarily regulated by the kidney, and the energy systems on the cell membranes, the ATP dependent systems, maintain not only the osmolality but also the electrical neutrality. Electrical neutrality is a lot more significant at the cell membrane level. Okay, go on. Yes. Next one.
So as we talked about the regulation of osmolality and homeostasis, what basically the homeostasis of the fluids in the body is the intake and output and the metabolism which happens within the body in a day. So on a general day, we take around 2.2 liters of water through food and the liquids we take in. And the metabolism generates around 0.3 liters of fluid per day. The loss through the skin due to regulation of temperature, and through the lungs due to humidification of the air we take in. And we excrete around 1.5 liters of urine and 0.1 liter of feces, fluid in the feces. If we calculate the overall output, overall input plus metabolism minus output has to be 0. If there is any increase in intake or any alterations in intake or output, results in retention or dehydration of the retention of fluid or dehydration of the person. So normal daily fluid requirement is water, 2.5 liters of water per day, and 80 to 100 milliequivalents of sodium is required, 40 to 60 milliequivalents of potassium per day. Calcium, magnesium, and phosphate in irregular, there need not be supplemented general basis, but in the case of abnormal GI losses or long-term starvation, they need to be addressed. Any change in the levels of sodium or potassium or chloride results in the alteration of acid-base balance in the body. So whenever there is loss of chloride, we get will land up in gain of chloride, will land up in hyperchloremic
acidosis. Yes.
And loss of potassium, we land up in alkalosis.
Yeah.
So in order to maintain all the things, homeostasis need to be in the place.
Yeah. Let me chip in here.
Yes, sir.
Just the point that she's trying to make is that while we are discussing only electrolytes in this class, they are closely intertwined with acid-base balance as well. So we will have a discussion on acid-base balance sometime, but please note that there is no independent change in the electrolyte balance in the body without a concomitant change in the acid-base balance. And that is also to be borne in mind, because without a normal pH, several systems in the body do not work properly, including the myocardial contractility or functioning of enzymes and things like that. So everything needs homeostasis, which is normal pH and a normal electrolyte content. And so when various disease processes put these things out of gear, all the other functions also deteriorate. So everything has to be seen in a global fashion. So you cannot study only electrolyte imbalance and leave it at that. But at the same time, we can't discuss everything in one class. So we sort of, if you like, artificially split it. But at this point in time, suffice it to remember for all of us the fact that any electrolyte shift will also, if result in some acid base shift as well. Okay, go on.
Yes. So this is the basic GI fluid constitution, which is very important because
Just stop there. Stop there. We'll ask. All right. Pavan is on call. Praveen. Okay, we have put up a chart which tells you the normal content of various secretions of the GI tract. Why do you think it's important when we talk about IV fluids?
Sir, sir, each part consists of different pH, sir.
Okay.
So, so the contents
we're not talking acid base today. We're talking about electrolytes,
Yes,
as
sir.
you said. So each part has different electrolyte constitution.
Yes,
All right. Yeah. So why is it important to a surgeon? All right, Krishna Kumari, do you want to take that? You know, please take it from me. Whatever I ask are very, very simple, no trick question, all common sense. As a surgeon, Krishna Kumari, you want to take that? Why would a surgeon want to know about the constitution and the volume of various secretions? Are you there? Vignesh, you want to take that? I don't know. Krishna Kumari is not responding.
Yes,
Yeah.
if a patient is in obstruction or he has a bile leak, so like, if a patient has a bile leak after a CBD repair, he's losing like more
Very
of
good.
sodium.
Very good. Very good. That's all
And
there is
if
to it. Okay. That's
the
all there is
patient
to
is
it.
having,
Yeah. So when the patient has an abnormal fluid loss, vomiting, large nasogastric aspirate, pancreatic fistula, biliary fistula, bowel fistula with jejunum and from ileum. So depending on where the output is, then if you measure the quantity of that loss, suppose you have put a bag and you measure that somebody has a bile leak of about 1 liter in a day, or 1.5 liters in a day. If you don't have to mug this up, but if you go back to this slide, or this information is available everywhere, if you know how much is lost, then you know there is 1.5 liters lost, which means 150 plus 75 milliequivalents of sodium, not a lot of potassium, but a considerable amount of chloride. So you know how much you have to replace. So each day, apart from the 2.5 liters that we mentioned, everybody, even if they don't lose anything, they need 2.5 liters of water, in which they must have about 90 to 100 milliequivalents of sodium and about 60 milliequivalents of potassium. And to that, you add the 1.5 liters of, say, bile that is lost, which means you must give them a total of 4 liters of fluid, of which, in addition to the 100 milliequivalents, you have to give them another 225 milliequivalents of sodium, and similarly chloride and the rest. So your replacement of fluid, intravenous fluid, becomes scientific and physiological when you have this knowledge. So it's no need for you to mug up these things, but you must know where this source is. This table is available. This table is actually taken from current surgical diagnosis and treatment, and you have this in several other books as well. So have this handy. So when you have a patient on the ward who is losing a lot of gastric content, for example, then you know how much of sodium is lost, how much of chloride is lost, depending on the volume, and you add that to the normal daily requirement, and your fluid replacement will become scientific and physiological. This is the kind of thinking you must have when you write your IV fluid order for a patient in the ward. Most of the time, we sort of write 2 salines and 3 dextrose a day or something like that. Very casually we approach that. That is a wrong thing. The purpose of this class is for all of us to learn that there must be a scientific basis of replacement of IV fluids. Go on.
Yes. Shall I skip to next slide, sir?
Yeah.
It's okay. Why do we need to give IV fluids to a patient or to a patient? So first thing is, the first indication or first reason we come across is resuscitation. If the patient has a major loss of fluid, we immediately go up with resuscitation. And what do we do there? We replace the fluid which has been lost. We replace the volume, we replace the electrolytes, we replace the sugars, not just only the volume. And the other reason which we give IV fluids is maintenance of the patient. If the patient is in ICU and he's unable to take anything perorally, or there is some kind of obstruction, and we need to maintain him intravenously, in that case we give IV fluids. And can anyone define or talk about fluid creep? What is fluid creep?
You ask somebody, otherwise we'll have long silences. Vinod,
No, sir, I didn't know.
you don't know.
Yes.
Yeah. We have a
Giving excessive fluids, sir.
F62. Sorry, one sec. We have a F62. Who is that, please? What's your name? Can you unmute yourself and give me your name and where you're from? F62. The list shows F62. Who is this, please? All right, no response. All right, Indraja, were you talking about it? Please go ahead.
So is it that fluid overload, sir, like redistribution of fluids?
Yes, but where does it happen? It happens in a very particular situation.
In burn patient, sir?
Yes, correct. Go ahead. Talk about fluid creep, Nikitha.
Fluid creep is actually, what I have read is, it's basically the amount of fluid which has been given during the medication, sir. Like when we give, other than the intravenous fluids, like during the administration of antibiotics and other medications, the fluid which we give is considered under the fluid creep, sir.
Yeah, no, there is that could also be considered fluid
Yes, sir.
creep, where you don't actually mention it. As inotropes and antibiotics that you give, you must include this in your fluid balance, and you normally don't do it. But originally, fluid creep was a phenomenon described in burns.
Yes, sir.
Okay, where there are many formulas. Parkland is the most popular formula, okay, for replacement of fluid during burns. And they found that even though it was done on a fairly scientific basis, there was always a situation where you could have an overload of fluid, and one had to be careful about it, and one had to have different kinds of monitoring. I think you're going to talk about monitoring later. So in addition to a formula-based replacement for fluids in burns, you have to have a monitor to make sure that you're giving the correct amount of fluid. That is a phenomenon of fluid creep.
Yes, sir.
In essence, once you have calculated your fluid requirement and given it, you can still err on the side of over administration of fluid because of this phenomenon of fluid creep, which happens with formulaic replacement of fluid in burns or in unknown situations where, for example, as you said, you do not count the fluid in the IV fluid, in the antibiotics and inotropes and things like that. Okay, that is the phenomenon of fluid creep. Go ahead.
Yes. So next, what are the types of intravenous fluids that are available now and which we use in a normal practice? Basically, there are two types: crystalloids and colloids. Crystalloids are again of three types. They are called crystalloids because the major component is saline, which is a crystal. They are of three types: isotonic, hypertonic, and hypotonic. Isotonic crystalloids are normal saline, ringer lactate or ringer acetate, and plasmalite. Hypertonic solutions are 5% dextrose in saline and 3% NaCl. Hypertonic solutions are majorly used in the cases of hyponatremia or increased intracranial pressure. In those situations, these cause an osmotic gradient and reduce the cerebral edema. And hypotonic solutions are 5% dextrose and 45% saline. These are mainly used in the cases of excess diuresis and slow rehydration and hypernatremia. In hypernatremia cases, isotonic fluids are mostly used in resuscitation. So, what is the major difference between ringer lactate and ringer acetate is the question again.
Go on, anybody? Sriramulu? I think you guys must be more active here. If you're if you're really listening to us, please unmute yourself and start answering. If you do not know, feel free to say you do not know. There are many things I do not know. So many times in classes, I go and tell them, let us look it up. Okay, go on, Sriramulu.
Yes, sir. Actually, I have no idea.
You have no idea. Okay, go
No,
ahead,
sir.
answer. And that's fine. That's all. We need a quick answer. We're all here to learn. There are many things I don't know. I have no doubt about it. All right, go on. Nikitha, give them the answer.
Yes, sir. Ringer lactate, which is being used since long, it's a physiological solution. The major metabolism of ringer lactate happens in the liver, which converts the lactate into bicarbonate. Ringer lactate is not used in the shock. It's not being used in the shock now because it has been shown very adverse effects. So they came up with ringer acetate, which is metabolized in the muscle, in the peripheral muscle, into bicarbonate, and it is very safe to use in shock situations, and it's mostly advised in lactic acidosis conditions, sir.
Yeah, but actually it's not very easily available.
Yes,
and
sir.
not very commonly used, but you're right that there is a shift away from Ringer's lactate to Ringer's acetate nowadays. I agree with that. Yeah, go on. Now, I have another fundamental question here. We're talking about osmolality, and suddenly we now talk about tonicity, isotonic, hypertonic, hypotonic. What's the difference between the two? Indraja.
Sir, isotonic means it is a osmolarity as that of our plasma, sir.
So in other words, what is the difference between tonicity and osmolarity?
I'm not
All
sure.
right. The answer is very simple. They both describe the same phenomenon of solute load. Osmolarity is a measure of the solute content of the plasma.
Okay. Sir.
Okay. Right.
Yes, sir.
So what are the solutes that you see in the plasma? This is a very fundamental thing we need to understand. What adds to the, or what gives rise to the osmotic tension of
So
plasma?
proteins, sir,
Proteins,
all and electrolytes.
electrolytes, good.
Uh,
Anything else? These are the main ones, I agree. Electrolytes must come first, and then the proteins, and even sugars.
yes, sir.
Okay, so
Yes,
and many products of metabolism. There are many products of metabolism circulating in the blood. All those things give you, but mainly you're talking about the electrolytes and proteins of the blood. I agree. Okay, so this is the one that gives rise to the osmotic pressure, and there is a characteristic of a solution. Okay, the characteristic that tells you the solute load in a solution is the osmolarity. Okay, and the characteristic which determines, it's the same thing, the same solute, but the aspect of these solutes which determine the osmotic pressure or the oncotic pressure that sometimes people talk about, that is the pressure gradient across a membrane, that is called tonicity. And that characteristic of the dissolved solutes determines the fluid shift. Okay, and so
yes,
when you describe a fluid, when you described its tonicity, it tells you that this is the same tonicity or a solute concentration as plasma. So when you put the two together, there is no fluid shift. They're all the same. If there is hypertonic, then it draws fluid, and if it is hypotonic, it pushes fluid out. Okay, so
yes,
the phenomenon or the aspect of a solute load which determines the pressure and the movement of fluid is called tonicity. Got that?
yes, sir.
It's as simple as that. Okay, go on, Nikita.
This brings us to the concept of balanced solutions. It generally means they are the solution which we are going to administrate is very similar to the plasma composition, so that it just balances without the tonicity is balanced more.
Yeah.
So
when you push that fluid into the plasma or into the peripheral system, there is no shrinking or swelling of any of the cellular components of blood. That's all it means. Okay. All right.
yes.
Go on.
So the normal compositions of the the picture depicts. First, we'll talk about plasma. The normal composition of plasma, it has, as sir mentioned, electrolytes and albumin, which is a protein, and bicarbonate. These are solutes. But the normal saline which we administer has only two electrolytes, that is sodium and chloride. So this is not a balanced solution, whereas ringer lactate and plasma light are considered as balanced solutions because they have the composition very close to the plasma with sodium, chloride, lactate, and potassium.
Yeah, essentially their pH in balanced solutions, their pH will also be as close to the plasma pH as possible, whereas NaCl is an acidic solution. But we have used it right and left, and in a person with a good kidney, it doesn't make a huge difference. Okay, yeah, go on.
These are the normal compositions of the fluids which we have mentioned before. Here you can see that now the question is, what is the normal osmolarity of plasma? By only then we can classify these solutions as hypertonic or hypotonic. So
Correct.
what is the normal osmolarity of plasma?
Praveen.
Sir,
What is the normal osmolarity of plasma?
290, sir.
Yeah.
Milliosmoles.
All right. Okay. Go on.
Uh,
Go on, Nikitha.
yes, sir. So here we can see that there are hypertonic solutions and hypertonic solutions. Based upon that, 0.9% NaCl, which is 308, is close to the plasma osmolarity, so it is considered as isotonic.
Yeah, half normal saline, which is 0.45, is hypotonic.
And 3% NaCl is hypertonic.
Hypertonic. Yeah.
And,
Yeah, like that. Okay.
yes.
So you don't have to, but
Okay.
you have given, yeah, we now have an idea how these different solutions are, are based or classified as hypo, iso, or hypertonic. Yeah, go ahead. Next slide. Just hold on for a sec. Just hold on for a sec. Pavan has asked a question. No, Vinod has asked a question. LC bleed hypertonic solution. What is the question, Vinod?
She mentioned as in the intracranial bleeding, we will give hypertonic saline. So is that true, sir?
In special circumstances, yes. If you have a lot of brain edema, for example, in trauma, you may
in
choose.
edema we can give, I think. In bleed we can give, I think.
Well, there is, in a bleed, you will have a, what is the basic problem with a bleed? Once the bleed has stopped, okay, obviously you need to stop the intracranial bleed depending on what the source is. And then what is it that causes the secondary damage of an intracranial bleed? It is the edema, okay? Brain edema.
Yes.
That's why you closely monitor the intracranial tension. You can give mannitol, you sometimes give hypertonic solution. More importantly, you can do a craniectomy and allow the brain to swell to reduce the overall morbidity. So it's one of the methods, okay? All right, go ahead. Go on.
And sir, clinically, dextrose, I heard it, dextrose is a hypotonic saline clinically because of action with insulin, this whatever the dextrose will be
Used up
and leads to it is converted into hypotonic.
It is like
saline.
free water, like giving dextrose. 5% dextrose is giving like free water. That's right. That's right. Yeah. But there is no conflict in what she has said, no, in that. Is there a conflict?
Yes, sir.
Is there a conflict?
No, sir. Just I'm asking.
Quite right.
Can
Okay. Yeah, you're just asking, you're right. So, see, that's another aspect. I will not get into it now because it can confuse people. So if you're looking at all this, you must also look at what is it in a bottle and what happens to it after you put it to the patient, after the metabolism of the constituents. But let's not go into it just now. Let us understand the more fundamental issues. Go ahead. Nikitha. Yeah.
The pros of normal saline are they're good for initial resuscitation because they're isotonic and they're cheap and readily available. Whereas the cons are because of the presence of higher chloride levels, it causes hyperchloremia, hypernatremia, and which lands the patient in metabolic acidosis.
Yeah.
And large sodium load.
Okay.
It needs to be used with care in heart failure and renal failure patients.
Yeah. Well, let me just go back a little bit. Yeah.
Yes,
let me put this question. We have Arya here. Can you unmute yourself? Tell me who you are, please. Arya, can you unmute yourself? No response. Krishna Kumari, can you unmute yourself?
Yes, sir.
Yeah. If I ask you to write IV fluid order for a patient who is nil oral but has no other issues, okay, 24 hours, what would you write, ma? No trick question. What? Tell me what you do in your ward.
Yes.
Sorry?
Yes, I'll write DNS, sir, 100 ml per hour. If there are
DNS
no
100
other
ml per
comorbids,
hour.
patient-
Okay, so it means you're giving 2.5
if
liters
the
of
patient is NPO,
yeah, you're giving 2.5 liters, okay, of DNS. Is that right? 100 ml per hour. Is that right?
Mm.
Krishna Kumari, is that right? 100 ml per hour, 24 hours is 2.5 liters, 2,400 ml. I made it 2,500. All right. So tell me, what would be the sodium you are giving, the potassium you are giving, and the
yes, sir,
chloride
2.5
you are
liters.
giving? Sorry?
Yes, sir, 2.5, yes.
Yeah, you're giving 2.5 liters. So tell me, how much
Mm.
sodium does 1 liter of DNS contain? You go back, Nikitha. Let us see what the table showed. Can you see that? D5.9 NaCl is your DNS. Okay. So how much sodium does it contain, ma?
Yes, sir. 154 milligrams.
Per liter. Remember, this is per liter.
Yes, sir.
So how much sodium are you giving?
I think 450, 375.
Yeah. All right. 154
Yes.
times 70 is 200 and approximately 220. Okay. 230 per liter. You're giving 2.5 liters, which means you're giving 600 milliequivalents of sodium. All right. Did you understand that?
Yes.
Okay. And no potassium, no calcium, no lactate. So and what was the normal requirement we said?
Sodium is 80 to 100.
Right. So you're giving 5 times or 5.5 times the normal requirement of sodium.
Yes.
Okay. I think the purpose of my class is already served with just this one question and this just one answer. Don't feel bad about this. Understand? None of you need feel bad about it, because we teachers haven't taught you these fundamentals. All right. We have not, when we do our rounds, we have not criticized you when you are a first year student to say, look, how much sodium are you giving and what is the requirement of the patient? That simple question we should have asked. We didn't. All right. So don't feel bad about it, but go back and think about it. And so what should you give if now that you know you're giving 5 times the requirement of sodium, how would you give him something which is as close to 100 as possible? What would you do? What would you do? As close to 100 as possible. What in this selection of fluid that you have, what would you do? Just see there, the answer is there for you. So if you give 1 liter of Ringer's lactate or 1 liter of plasma light, it's also called isolite M, I think, in India. Isolite M or Ringer's lactate. If you give that, you're giving 130 milliequivalents of sodium, which is very slightly above what they should need. You can give of course, you're giving hypokalemia. They need 50, 60 milliequivalents of potassium, but you're giving 4 or 5, which is okay, which is, if you want, you can add supplements, but generally not required in the short term. And so you're giving only 1 liter. So how do you make up the rest of the 1.5 liters? How do you make up the rest of the water? How do you give free water? You need to give the volume. No, they need 2.5 liters a day. Tell me, Krishna Kumari, tell me, Ma, what do you give? Just water. You can't give water. It has to be isotonic. So what is free water, which is an isotonic solution?
D5.
D5. All right. It is D5. Nothing, no great shakes. So what I usually recommend writing, and what I used to write myself when I was writing these fluid orders, I don't write them myself nowadays, but my residents do. But anyway, what I used to do was to alternate Ringer's lactate with dextrose. Okay, and start with dextrose. So 1 unit of dextrose followed by RL, another dextrose, another RL, and another dextrose over 24 hours. So when you do that, you have given them 2.5 liters of IV fluids per day, and 130 milliequivalents of sodium, and maybe 4 milliequivalents of potassium. And if somebody you feel is hypokalemic or doesn't have the capacity to make up for it through a good kidney, you may give potassium supplements. Usually it's not required in a normal post-operative phase where there aren't any excessive losses of potassium. Okay, you got that? So from tomorrow, I would like all of you to think about it when you write your IV fluids in your wards. Go ahead, Nikitha.
Yes. So as I have mentioned before, it is physiologic, and it's Ringer's lactate is more expensive. It worsens the brain swelling, and now it is not used in shock and renal failure.
All right.
In a recent trial, it had been shown that balanced crystalloids are better than normal saline. As excessive normal saline lands the patient with renal failure and renal replacement. In critically ill patients, the patient might need renal replacement.
All right. Just the message there is balanced solutions are preferable to normal saline. Go ahead.
The next type of colloids. Colloids are of the basic examples of colloid are albumin, hydroxyethyl starch, gelatins, and dextrans. Why do we use albumin? What is the specialty of albumin? This is a question again.
Yeah. Ask somebody. Don't leave it open. Who do you want to answer? Who do you think should answer?
Vinod, sir.
Vinod, go ahead. Yeah.
Hello, sir.
Yeah.
Sir, albumin is it is synthesized, sir, and it is more similar to our body protein, which is albumin, and it has only 24 hours of T-off, sir.
Mm-hmm.
And
but why do you want to give it instead of Ringer's lactate?
It has it increases the osmolality, sir. I mean colloidal osmolality, that interstitial fluids will be pulled into the intravenous fluids.
Yeah, it stays in the circulation longer than a crystalloid.
Yes.
Crystalloid.
Okay, that's the main point. Yeah. As Sri Ramalu has answered, it maintains the oncotic pressure, and so you can give it, but it has several disadvantages. So even if it doesn't stay in the circulation much, even in a patient who is hypovolemic, you can make up for the lack of oncotic pressure, even though when you give crystalloid, you can make up for it. How do you make up for it? You give more of it. All right? You give more of it, taking that it doesn't stay much in the circulation. So in essence, you give about 3 times the calculated amount of fluid that you want in the intravascular volume. All right, because only 1/3 of the crystalloid that you give stays in circulation. So give 3 times that and it will stay there. And okay, go on. You have to tell us about the disadvantages of albumin now. Go on, Nikitha.
Me, sir. Okay.
Yeah. Because go on.
Okay, disadvantages of albumin are it's
if you don't know, say you don't know.
I'm not exactly sure, sir.
Not sure. Yeah, go on. Sri Ramalu, do you know the disadvantages of albumin?
Hello.
Extremely expensive. All right. It is extremely expensive, not as easily available as a crystalloid. And even though it is highly debatable, I in fact gave a whole talk on crystalloid versus colloids in resuscitation. Okay. Even though it is debatable, people say that the morbidity and mortality with albumin resuscitation in a patient in shock is actually worse than that with crystalloids. And I am the first one to say it's debatable. This debate is going on for 30 years. It has not been resolved yet. But there is one school of thought that albumin is less safe than crystalloids in resuscitation for shock. Okay, remember that. And also it's extremely expensive. It's not required. So about the only situation where albumin is now used clinically is in a patient with chronic liver disease, is hypoalbuminemia. If you're treating ascites, if you have drained the ascites, for example, unless you replace the volume with at least 25% of that volume with albumin solution, then the ascites will form again very, very quickly. So for you to have some degree of lasting effect of the drainage of an intractable ascites in chronic liver disease, it is useful to give them some albumin. Other than that, in normal clinical practice, you rarely ever use albumin for resuscitation. Okay, continue.
Yes. Starches are made from plant extracts, and they are also very expensive, and the side effects of them are persistent itch, coagulopathy, exacerbation of acute kidney injury, and risk of anaphylaxis. Whereas gelatins are semi-synthetic colloids made from animal connective tissue, that is from collagen. It has high risk of anaphylaxis. And dextrans are made from glucose polymers. It can cause hyperglycemia and hyperosmolarity, as it also contains sodium chloride, and it's a hyperosmolar intravenous fluid, dextran.
So when you use all these synthetic colloids, please bear in mind 3 or 4 possibilities. Acute kidney injury, they have a higher incidence of kidney injury. They can cause coagulopathy. That's another point. And some of them, in addition to the basic molecule, which is a starch or a dextran, also have a lot of sodium. And so you end up with giving them a lot of sodium. 3 things you have to bear in mind when you give albumin substitute colloids. Okay, and this table shows that.
Yes, sir.
All right, next slide. Yeah.
The ALBS study, which was done in 2014, it showed that there is a lower risk of death in septic shock when albumin was used when compared to crystalloids. And the safe study in 2004 shows that there is high mortality in traumatic brain injury cases where albumin was used.
Yeah. So this is the point I made. It is still controversial. So if an examiner asks you, or even as a practitioner, you can say there is controversy about albumin use in shock, particularly in septic shock. And so you need to have both in mind. In a given situation, if you find that you're unable to maintain the hemodynamic stability with crystalloids, you can use albumin, but that can be very, very expensive. Sri Ramalu, your hand is up. Tell me, please.
Sir, what is your take on using fresh frozen plasma for resuscitation, sir?
Not at all to be used, because I'm a great believer in crystalloids. Fresh frozen plasma again is expensive, and its primary use is not as a source of protein or albumin where you want oncotic pressure. Its primary use is to infuse coagulation factors where they are lacking, as in chronic liver disease with coagulopathy, where you do not have either the time for vitamin K to work, or you do not have the capacity with the degree of liver failure. They may not produce enough coagulation factors. In those cases, you give a fresh frozen plasma, not as a fluid replacement for resuscitation, not to be used at all.
As a protein supplement for a case of hypoalbuminemia, can we use FFP, sir?
Yes, if you don't get albumin, you can use it, but the concentration of albumin there would probably be less than you have dedicated albumin solutions.
Yes, sir.
She mentioned
Like
about 4.5. There is also a 7% albumin solution that's available.
Yes, sir.
So
Yes,
that would
sir.
be useful in, as I said, CLD in ascites and things like that. But if there is no availability of albumin, perhaps you could consider FFP. Yeah.
Yes, sir. Thank you, sir.
All right. Go on.
A success study in 2012 showed that there is a higher risk in severe sepsis, and there will be need for renal replacement if we use starch. It was compared to ringer acid in that study, which was Scandinavian starch for severe sepsis and septic shock study. And where do we give the intravenous fluids? It can either be given by peripheral line or a central line. And peripheral line can be given directly or by USG guided, and midline catheter is there. Central venous catheter is also of two types, which is non
Nikitha, there was a break. Is there a problem with your connection? Hello, we have lost you, I think.
and we need to immediately resuscitate a patient. We'll go for the intraosseous route, which is an immediate access.
Yeah, it is very uncommon in adults to have to do that. Sometimes it's done in babies.
Yes.
Okay, intraosseous route. It is there to be described, but today, even in a collapsed patient, getting a central line is a skill that all of you surgeons must have. Okay, you must learn in the OT, go to the anesthetists and learn to put a central line. That's a very important skill for you to have. So even if somebody is hypovolemic, almost certainly you will get an internal jugular or a subclavian access and you can give fluids quickly. Intraosseous need in an adult is very, very rare. Go ahead.
Okay. And how do we give that? We continuously infuse the patient with IV fluids, or they could be intermittent. In intermittent, it can either be piggyback or direct injection caps, or a direct injection, which is a bolus, is also a way of giving intravenous fluids. The equipment, it can either be manual, which we see in the wards daily, or it could be electronic pump flow, which we see in ICUs, where they use infusion pumps. So as we have discussed that fluid should be considered as a drug, the 4D stewardship is also applicable here, where we talk about the kind of drug we are giving, what amount of the dose we are prescribing, and how long are we going to prescribe the fluid, and when do we stop the fluid. So the specific fluid for specific indications is very important in fluid therapy, and dosing depends upon the fluid. If glucose remains 10% intravascular, whereas crystalloids are 25% and colloids are 100% after 1 hour. So depending upon their stay or distribution, we need to prescribe the dosing, and duration is also considered. De-escalation is when do we need to stop the fluid. Fluids can be stopped when the condition is resolved or there is no further role of fluid resuscitation.
Nikitha, move your slides to show them that picture. It's much more understandable when you do that. Yeah.
That is phases, sir.
Yeah. Go on. Yeah.
Okay.
Let me not stop your flow.
Okay, sir.
Go ahead with whatever you want to do. Yeah, go ahead.
Okay, the terms which are important in fluid therapy, that is resuscitation, which is time dependent. Resuscitation means administration of fluid for immediate management of life-threatening condition associated with impaired tissue perfusion. Whereas titration means adjustment of fluid type, rate or amount based upon the context. De-escalation, as we said, it is minimization of fluid or stoppage of fluid. And rate and volume dependent terms are fluid bolus. Can anyone say me how much amount of fluid needs to be given to consider it as a fluid bolus, and over what time?
500 to 500 ml to 1000 ml, 500 ml over 15 minutes, sir. It's considered fluid growth.
Yes,
Go on,
sir.
go on, answer quickly. Nikita.
Yes, sir.
Yes, sir. Yes, sir.
That's right. Yeah,
That's
okay.
the answer.
Yeah,
And
go ahead.
fluid challenge is 100 to 200 ml over 5 to 10 minutes. With reassessment to optimize the tissue perfusion. Whereas fluid infusion is continuous delivery, maintenance is for who cannot meet their needs. Daily fluid balance, cumulative fluid balance, and fluid overload are important terms, which involve a day-to-day reviewing of the patient, in which we write the intake and output chart and the negative or the positive result which we get. The positive result which we get is the positive overload, and negative is the loss of fluid. Vincent and Debacker have divided fluid therapy into 4 phases, which include resuscitation, optimization, stabilization, and evacuation. So this is called as Rose model. So resuscitation is the first step of the fluid therapy, in which there is immediate fluid boluses, rapid fluid boluses are given in order to save the life of the patient, which we generally see in septic shock or major trauma. It occurs within a few minutes, a few minutes. Then the next stage is optimization, in which we aim for tissue perfusion, and it takes place in the next few hours. Even in this stage, the patient is unstable, which we generally see in the scenario of burns or diabetic ketoacidosis. The next stage is stabilization, which happens over few days. In stabilization, we see that the patient has reached the stable stage, and we aim for zero fluid balance, and minimal maintenance of infusion is only preferred. The final stage is de-escalation, where we aim to stop the fluid, and oral intake is encouraged. It takes place in the next few weeks. So during
Okay,
all
just
the
go back one slide, Nikita. Yeah.
Yes, sir.
I know I'm overshooting a little bit. It's 10:03, but I think it's an important topic and we'll finish fairly quickly. I just want to summarize this to give you a basic concept. And I'll take the example of a septic patient in a septic shock. Okay. So one of the first things that you do is, I won't go into the septic shock itself. You know the surviving sepsis campaign and the 3-hour requirement, the 6-hour requirement, and things like that go with the surviving sepsis campaign. First, you give a lot of fluids. Remember that even in septic shock, the basic pathology is still hypovolemia because of the leakage. Everything has third spaced, and so intravascular volume is low. So you give boluses to make sure that you reach a CVP. As you know, it is called a goal-directed therapy. So you give enough fluids to make sure that you have the CVP above 10 and have a mean arterial pressure of more than 65 and a urine output of at least 0.5 ml per kg per hour. That's 30 ml per hour generally. Then as soon as you have stabilized the patient, you need the optimization, where you want to prevent the MOF, multiple organ failure. And so that lasts a few more hours. And so continue your major perfusion. If necessary, use inotropes, high antibiotics, and a source control. If you have some obvious source and intra-abdominal abscess that you can drain, you drain that. Then once that stabilizes, you have a period of stabilization where you reduce the volume of fluid. So on a given day, as soon as the patient comes, overnight you might have infused 5-6 liters of fluid. In the next 24 hours in the optimization, say you might have infused another 5-6 liters. And so you may be positive by 5 to 6 liters of fluid in the first 24 to 48 hours of the patient after the rescue and the optimization phase. When the stabilization comes, then you have a zero balance. Okay, that means you do not give more fluids, you give as much fluids as is the output. And that is stabilization. That may be for a few days. Once the sepsis gets over, then you reach the stage of de-escalation. Sepsis is over, organ function has improved, and you find that at this point you have to give much less fluid than the output. Remember, the patient, by the time it is 3-4 days, by the time the patient has come out of sepsis, he may be in 8 to 10 liter positive balance. He will have a lot of fluid in the third space. Once the sepsis gets better, they mobilize the fluid themselves. What was all in the third space comes back into the intravascular space. And one of the first things that you notice is that without any support, the urine output increases. That's when you should not chase the urine output. If somebody has 3 liters of urine, you can't give them 3 liters. That's when you still have to give them only 1 liter of IV fluids or 1.5 liters of IV fluids, so that the patient is mobilizing the third spaced fluid, and that is the concept of de-escalation. So you can easily be in negative balance of up to 2 to 2.5 liters a day. And if that happens over the next 4 or 5 days, they will have got rid of all their third spaced fluid during the recovery phase. Okay, I hope you understand that basic concept. So in the initial phase, push fluid, don't keep looking at, oh, I've given him too much fluid. He needs that to live. And then as the days progress, as the pathology, basically the sepsis gets better, you can de-escalate. That is the concept. Next slide.
How do we assess the patient during these 4 stages of fluid therapy? Continuous monitoring of blood pressure, heart rate, and ABG, capillary refill needs to be done throughout the 4 phases. Whereas altered mental status is only fixed to the rescue phase, because after optimization, the patient is mentally, most probably is mentally stable.
Correct.
Urine output should only be considered from optimization state, because during the rescue stage, he'll be in the patient is in shock, so it doesn't give the right assessment. And fluid balance is also considered, as sir has mentioned, from optimization state. For optimum monitoring, we need to go for further evaluation investigations like Doppler, which are done in first 2 phases, and CVP monitoring is done only during optimization, which is more preferably done. Saturation of central venous oxygen is monitored in optimization and the later stages, whereas cardiac output is also been considered from optimization. Signs of fluid responsiveness are seen in optimization. Fluid challenge is also considered in optimization phase. So when to do the when do we need to transfuse fluids? What are the major causes? Their trauma in the
you
case
can
of
skip
trauma.
these. These are pretty
Okay.
self-explanatory.
Okay, sir.
Okay, we also have gone on for quite some time, so let us finish the class. I think the basic concepts have already gone in. So go on, continue. Go through them quickly. Yeah.
I'll just finish.
Yeah.
Yes, sir. So majorly in surgery, when do we do these transfusions? Preoperatively, before surgery, during surgery, post surgery. So before surgery, as a patient is in fasting, we are supposed to supplement him with the fluids in order to meet his daily needs. And regarding clear fluid intake, it has been encouraged by the recent studies that till 2 hours before the surgery, clear fluid can be given to the patient. This makes our intravenous fluid infusion less relevant in case of before surgery. And one of the important fact to consider for fluid therapy before surgery is a case of hypotension. To know whether the person is in hypotension or not, we need to assess him priorly. But clinically, we can do it by passive leg raising test, which shows us if it has any change in the stroke volume. We need to consider him as an hypotensive, and he requires fluid therapy.
Hypovolemic. Yeah.
Yes, sir.
If somebody is hypovolemic, then if you raise the legs, it increases the venous return and the pressure comes up. And so for him to have the amount of venous return or cardiac filling without leg raising, just give them fluids. That's all. Give him a liter of Ringer's lactate or whatever, and that will look after the slight fluid deficit that he has. Yeah, go ahead.
Yes, sir. Intraoperatively, there are liberal approach, restricted, and goal directed approach. Liberal is the old one, which they used to give 6 liters of fluid on the day of surgery, whereas restricted approach, it gives only 4 liters of fluid, which aims for the balance of only 1 liter of post operatively. So due to the recent advancement of ERAs, enhanced recovery after surgery, and restricted fluid management, we are aiming for zero balance during the surgery. So fluid retention is basically calculated by weight gain. The disadvantage of restrictive fluid is acute kidney injury is reported in many cases where restrictive fluid is sorry, sir. Liberal approach is accepted.
Yeah, but bear it in mind that on an average, about a liter for an adult, 60 kg adult, about a liter per hour is the IV fluid requirement during surgery. Okay, that is the amount of volume that you need. Next one, please.
Okay. The other one is goal-directed fluid therapy. It is mainly done to optimize the stroke volume. So, it's the main aim is to monitor the blood pressure and see if the patient needs any fluid requirement. So, individual plan is promoted in interest trial. Post-operatively, early oral intake is encouraged due to enhanced recovery after surgery, and the relief study shows that the patients who are critically ill and who have impaired oral intake, they should continue the IV fluids. We shouldn't go for stoppage of fluids. This new substitute for intravenous approach is hypodermoclysis. It's mainly used in the patients who are in ICU and elderly patients. It is a subcutaneous approach for the fluid administration, sir.
Yeah, I mean, I think you're mentioning it for the sake of completion. I wouldn't go into its details. It's not really commonly used and not very relevant. Okay, all right.
So by considering fluid as drugs, we need to apply this point in fluid therapy. Like all things are poison. It's simply the dose that distinguishes between a poison and remedy. So the right dose given at the right time to a right patient only works as a medicine. If we do not consider the metabolic complications, it lands as a poison.
Yeah. All right. Thank you. Thank you. I have attached in the chat box 3 references. You should be able to download them. Please download them and read them. They are good papers on IV fluids. Okay. Any comments or questions before we close, please?
Sir, I have one doubt, sir.
Yeah.
Sir, in the post-operative period, if the patient had oliguria, whether we have to give excess fluids or not, because some studies are telling that oliguria is common, we no need to give fluids. Otherwise, they will go into retention, fluid overload.
Yeah.
Yes, sir.
See, this is the concept of goal-directed therapy.
Yes.
Right. The goals are very simple. You want to know the euvolemic state of a patient. put a central line. CVP of more than 10. Mean arterial pressure of more than 65. Some people say 60, some people say 65. And if you have a CVP of more than 10 and a MAP of less than 65, give them inotropes to bring the MAP above 65. And then you make sure that the patient makes, then they'll usually make at least 30 ml per hour. I'm talking about a 60 kg adult, okay, 0.5 ml per kg per hour. That is the goal that you need to start with. Okay, so 30-40 ml per hour of urine in an adult, MAP of 65, systolic maybe 90, CVP more than 10. If that's all you have to do. Now, if you have a high CVP, a good blood pressure, MAP more than 65, 70, 75, you do not have urine, you can give them some Lasix as a diuretic to improve the urine output. If that also doesn't work, then you have to go on to the acute kidney injury protocol. That's when you have to involve a nephrologist, and they will watch. Again, they also have the same therapy. Some people give them Lasix infusion at 1 to 2 milligrams of Lasix per hour as an infusion. And if that also doesn't work for them, then they may have to have a temporary dialysis. And at all times, you have to look at the source. If it's sepsis that has given, if it's a toxic drug that has given AKI, withdraw the drug. If it is sepsis, use the appropriate antibiotic and have source control. That is the role of the surgeon. All right, you must have source control. So this is the protocol, and so the goal-directed therapy is important. So if somebody has problems with urine output, somebody has problems with pressure, you have to put a central line and monitor the CVP. You saw the chart on the monitoring that she mentioned. All right,
Yes, sir.
that is where proper fluid filling and CVP is an important thing. She also mentioned echocardiogram and ejection fraction, that is the cardiac output, that can also be measured in higher centers with ICUs, but every center need not have it. Okay, yeah.
Okay, sir. Thank you.
Next, anything else? Abdul, you're still there? Sorry, there's some other
Yes, sir.
question. Some other question was there?
No, sir, nothing.
No, okay. Your final comments before we close, Abdul.
Very nice class. Something different to learn. IV fluids, you keep repeating the class, is always something different.
Yeah.
And I think Nikitha should have rehearsed a bit more regarding the flow or not there compared to her first class.
Yeah.
If she improves then it will be better.
Yeah. I agree with that. I think you did pretty well, Nikitha, but you really need to have a flow. You keep stopping when you're giving. So there must be a continuous flow, and that will come with time. You need to make a few more presentations. You're still in the beginning of your first year. By the time you finish, you come to the end of the first year, I'm sure you will have enough experience. Okay. Thank you very much for attending, guys. And as I said, you please download these references that I have attached in the chat box. And have all of you downloaded? Do you want me to wait before I close?
I downloaded, sir. I will
Okay.
forward it.
You can forward it to others also.
Yes.
Yeah. And so please keep in touch, and any questions or doubts you have, you're all most welcome to post it in the group and or to me individually, and I'll happy to answer those doubts if I know the answers. Okay. Thank you and good night.
Thank you, sir.
Good night.
Thank you, sir.
Thank you, sir. Good night.